On behalf of Juventus and Dr. P C Mahapatra, I, Alhad Mahajani, VP Marketing, accord a warm welcome to each one of the esteemed participants in this E-Gurukul of Dr. P C Mahapatra. On this Teachers' Day, we humbly thank Dr. P C Mahapatra for his valuable time, which he has offered us for this program. Just to talk about Juventus, Juventus has always been at the forefront as regards support to academic empowerment of medical fraternity. Juventus, to its credit, in the field of gynecology, has many first-time molecules. We were instrumental in launching Atosiban, which is Tosiban, Ivanu tablets, vaginal tablets, Istrin and pelvic gel. Juventus has been offers a contemporary nutritional basket as well, like Theronia XT and Corallium. We are sure that this E-Gurukul of Dr. P C Mahapatra would be a very interesting and kind of an academic feast for all of us who have joined in this beautiful program which has been designed.
And therefore, I have a soft corner for every people of that company, including Mr. Goa. When a proposal came from them that it will start on the auspicious day, Teachers' Day, about E-Gurukul, I had to accept the offer, and because it's a teaching session, teaching is my passion and treatment is my compassion, and therefore it's a pleasure that I'm talking to all my colleagues, viewers, teachers, students, friends, and everybody today. And when the topic came to me, I thought it's better to have a surgical skill transfer and the surgical tips and tricks of the techniques of the surgery, and it will take a long time, no doubt about it. But a good mentor is necessary, good knowledge is necessary, and your own effort and dedication is mandatory for that also. Now, when we speak of 21st century, it begins on 1st of January 2001 and will end on 31st December 2100. When we come to the evolution of surgery in the past, in the medical history, I find every third decade there is an innovation, and every 10 years or decade there is innovation. A new philosophy will come, an innovative idea and change will come in the history we have analyzed. You see the history, every 30 years there is an innovation. Say for example, I'm giving one, endoscopy. Endoscopy is an evaluation, video endoscopy way back in 1980s, 90s, the innovation started. But the innovation occurs every 10 years, every decade. A camera is there, but the changes in the camera from analog to digital, from single chip to 3 chip, from 2D to 3D, and so on and so forth. These are innovation, but the basic concept remains same as that. And maybe that after 3 decades again a new innovation will come. Now today the 1/5 time is over, and expecting a sea change in coming 80 years by the end of century for that. We do not know what are the advances in that, and there could be some changes for that. Now again, evolution of surgical skill we find out. From knife to chip, from hand to button, from visual to mapping, from minimal invasive to non-invasive, from day's care to day care, from pain to pleasure, from crowded to lonely OT, from human intelligence to artificial intelligence, and last but not the least, from mythology to science. Now the acquisition of a surgical skill has a different components. First and foremost, you should have a strong will or a commitment to learn. A strong will is necessary for acquiring a skill. Then only you can drill. The surgical mentor is absolutely necessary A surgical mentor is a must for surgical disciplines for that. And two things are important in surgery: decision and dissection. You may be expert in dissection, but if you lack in decision making, that is really not a good surgeon's aptitude. You can be a good operator, but you cannot be a surgeon, designated as a surgeon. So the combination of a decision and dissection, which one, whether not to do surgery or do this surgery, is important. I always say as a teacher, it takes 5 years to learn and do the surgery, but it takes 25 years to learn not to do the surgery. So decision is important, dissection is important for that. So both are important. In the era of technology, the gadgets-oriented surgery, you must be well versed with the gadgets. Clinical materials, analysis of the clinical materials should be there. And practice always makes a man perfect. No, it's wrong. Practice which makes a man perfect. It is not a practice makes a man perfect. If you learn a bad technique, whole life will devote for the bad technique for that. So perfect practice makes a man perfect. And after involving with the surgical steps, starting from assisting, then doing the cases for long years and exposed to thousands and thousands of cases, a process of automation comes. And once you get an automation, automatically your hand, your decision, your dissection will start and all that. And then you reach at a contribution of innovation. And innovation should be there to change some of the surgical skills for that. Now, surgical skill transfer when we mill. What are the methodology of surgical skill transfer? Visual. You see the surgery and visual impression comes to your hand and to the brain. So you look at a good surgery and seeing the surgery, I think you have a confidence building in that. And remember, therefore, look at a good surgery. If you be associated with the good surgeons and look at a good surgery for quite long time, you have absorbed that and a copy and paste will be there for that. You develop the same techniques in your brain for that. And this will be a copy and paste by visual and it comes to the brain for that. And it is a preceptorship is necessary. And when we look at a bad surgery, the same thing will come. So don't look at a bad surgery for that. Better avoid for that also. It is always be associated with good surgery for that. Mix and match. Your varieties of surgeons have different good qualities. The dissection of each individual steps is different for that. And you mix and match and find out and synthesize your own technique for that also. During the whole years of your dedicated practice. Remember one thing, surgery should be as simple as possible. Simplifying the procedure. All of you must be seeing that a person doing a surgery, looking at a surgery and assisting, you think that it is my left hand job. I can do it. Baएं हाथ का खेल है. And looking some surgery, you presume that I cannot in my life, I cannot do this surgery because the surgery becomes very complex for that person. So always simplifying the procedure is very important. Simplifying a procedure is absolutely a mandatory thing. Don't make the procedure too complex. Hemostasis. We have got a lot of gadgets now available. Good hemostasis is essential for dissection for that. Understanding the anatomy, the surgical anatomy, you must be well versed with that. And not only say surgical anatomy, the problem occurs with altered anatomy. Suppose there is a previous surgery, there is an altered anatomy, and there it becomes difficult to find out for that real anatomy. And you have to understand that altered anatomy, what could be the altered anatomy in that. Lastly, understanding the team and tool. In a gadget-oriented surgery, you need some of the tools necessary. You should understand the tools. The gadgets are bioelectronic methods where you must be well versed with that. The cautery, the camera, the endoscopic equipment, you must understand in detail and understand the team, the assistants, and whole of the staff involved in that. But the final is the mentor. I always say surgery, a mentor is necessary for that. To uplift your skill, a good surgeon is necessary for that. It's not coming. Next. Next. No. Previous. Next. Now, surgical experts, whether born or made, I think they're born as well as made. You can make it. You can acquire this skill. Now, Howell's model, there are 3 phases of surgical acquisition, how you can acquire it. First stage or first phase occurs unconscious incompetence. You are not knowing anything, unconscious, and you are incompetent in that. You carry out for few years. Then the phase comes conscious incompetence. You are conscious that this is to be done, this is not to be done. But competence is not there, you are incompetence. Then the last phase will come, unconscious competence. You are not conscious about it, but you are competent in that. You have gone to the auto mode, autopilot mode, like autonomous mode. Now, levels of skill acquisition is a diffuse and diffuse. There are 5 levels designated. Level 1 is called novice. Level 5 is called expert. But level 2 is an advanced beginner. Level 3 is competent. Level 4 is proficient. Now, psychomotor development in surgical skill transfer, there are 3 phase theory. First phase theory is a cognitive phase. Skill is understood and you are liable to make errors for that. Integrative phase is the second phase. You are more fluent. But third phase is an autonomous phase without much conscious effort. That's what I told, that is simulating with the autopilot mode. It is an autonomous mode. It is an unconscious, but it is a competence going on for that. Therefore, at the end, to simplify, we say the skill transfer, see one, do one, teach one. It is an oversimplification of the fact, but it takes a long time and a mentor is necessary. So Miller concept in 1990, from base to pinnacle, there are 4 things. First, he knows. Second, knows how. Third, shows how. And then ultimately does, and gone to the innovation phase. Now, coming to the implications and the development of art and science of surgery with special reference to gynecology. Advances in robotics is there, virtual reality, digitalization, telesurgery, simulation, and last but not the least, artificial intelligence. These are all innovations in the development of art and science of surgery for that. Now, the future is the age of information. The fundamental change from tissue and instruments to information and energy, from objects and atoms to bits and bytes, from macro to nano, from knife to chip. What is the expectation you have developed in the technological field? In the concept also you have elaborated. Now the expectation of future generation of patients is also changing. Now the patients, and compare with the yesteryears, there are a lot of difference in the temperament of these patients. Now the present generation of patients, the temperament is arrives in the office or from home. Verify infinite amount of time they want. They want instant diagnosis. They want immediate treatment without any complications, pleasurable surgery, and live with 200% cure rate. This is only possible when you are a physician as a superhero or a miracle healer. Sir Robert Hutchinson has told, from the inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, treating patients as cases from making the cure of the disease more grievous than endurance of the same. Good Lord, deliver us. Today's innovations are tomorrow's history. Tillian is beautifully written. One can only hope that the surgeon of the 21st century will not judge us too harshly and will realize that we are captives of the time in which we practice. So don't criticize the previous generation of surgeons that they were doing this surgery. I am doing better for them. You are captives of nature. As the nature goes, as age advances, as we progress, you are the captives of nature. Don't take any credit for that. Albert Einstein has told, as the technology is developing, I fear the day that technology will surpass our human interaction, the world will have a generation of idiots. So future of surgery, I cannot say in the next up till 2100, about 80 years is left behind in this 21st century. I don't know what will happen in the 21st century. What is the advances in every 30 years or 3 decades? There is some innovations. We can find an innovation. But certainly I can predict about the future of surgery in 22nd century. I presume, I dream that enchant a mantra, surgery is over. No dissection, no coagulation, no suturing. Just enchant a mantra, uterus will be out, surgery is over, baby is delivered. And if that is possible, surgery is over, surgeons are also over. And a new era of surgery will be coming soon. From the OT to the malas and babas and mamas, that will enchant the mantra. The change in the dress, the change in the place, everything will be changing for that. Thank you very much, ladies and gentlemen and viewers, for the initial talk on surgical skill transfer in 21st century. Allah, thank you very much.
Yeah. Thank you. Thank you so much for the initial talk. And I think so this has set the ball rolling.
I think audio video is all right.
I think so, sir. There was some disturbance in terms of audio in some places, but we are trying to rectify it from our end as well. So we are working on.
Now it's okay.
No, it's okay, sir. It's okay. It's okay. Okay. Somewhere there are some local issues, so people may not be able to hear, but we are working on that.
All right.
Yeah.
Just see for that.
Yes,
From
sir.
this side, there is no problem.
Sorry, sir.
From my side, there is no problem.
No, there is no problem, sir. There
Thank
could be
you.
some.
Because the next lesson will be a very common problem. Yeah.
Yes, yes, sir. Yes, sir. Dr. Diwan, sir, you can please take over.
Yeah. So with this, enchanting talk, I think it has opened up the new ideas and thoughts in the mind that what kind of newer things are going to be there in coming centuries. Dr. Mahapatra, would you like to take the questions at this stage, or should we go to the next lecture?
You can go next because the time is already short.
Okay, fine. Yes, sir. Please start, sir.
Yeah. The next session, I think, sorry viewers, due to some technological problem, I have been delinked with you. Now I hope I have again joined. The first topic is over. We'll start with the LSCS, cesarean section. Cesarean section is one of the very commonest surgery. Day in and day out, you must be doing this surgery. And for that, there are changing concepts about the indications, about the techniques, and about different evidence-based practices also. So people are confused about it, but for the general gynecologist doing every day in and day out is the common surgery. A good standardized skill has to be acquired for that, and that is the purpose of that. And I will ventilate some of the facts which I have learnt it. I have committed a lot of mistakes in my life regarding cesarean section also. I have seen many of the problems. I know what are the advances in knowledge and all that, but whatever is best for the patient, I will accept it. I won't accept anything what is not best for the patient, even if the literature says that it is good for them. Now, the basic concepts of any surgical procedure, selecting the right patient for operation. I think indications for that. Now, indication for cesarean when we come, I am reminded of one thing. 15 years back, when I was going as an external to the PG examiners, and I asked the examinee, what are the indications of cesarean section? Beautifully, they classify fetal factors, maternal factors, other factors, and they say about the indications. Now, when I go as an examiner, the examinee are more talented and they are more smarter than us. When I ask the same question, what are the indications of cesarean? They say, sir, the presence of pregnancy is an indication of cesarean section. So presence of pregnancy is an indication of cesarean section. Presence of uterus is an indication of hysterectomy. I think this is a very good simplification of obstetrics and gynecology for that. And therefore I say, don't be biased by that terroristic statement for that. It is absolutely unscientific to select an unindicated patient for surgery. Maybe that the rate of cesarean section is increasing. The indications may be increasing for obvious reasons, but selecting the right patient for surgery is absolutely important and the basic concept of any surgical procedure. Second important, selecting the right operation for the patient. If there are 2-3 methodologies, adopt the right operation for that particular patient for that. And that is important. Third important, most important is a skill acquisition. Performing the operation correctly. Doing the good techniques is very, very important, as I have again repeatedly telling that acquiring the skill is the greatest wealth of a professional. And fourth, you forget it. If you are doing a good piece of surgery, that is the most important post-operative care. Post-operative care, you do it, a good piece of surgery and forget it. I think majority of the complications of surgery are related to the surgical techniques. So post-op period, you forget it if you are doing a good piece of surgery for that. These are hard facts regarding cesarean section. Cesarean delivery is by far the most commonly practiced major surgical procedure in females. Current trends of increasing rate of cesarean section globally is there. Now there is an issue. Safety of cesarean section is a primary thing as a mode of childbirth, and that has to be considered in current obstetric practice. Safety first, both for the mother as well as for the fetus. Safe anesthetic techniques, effective antibiotic prophylaxis, facilities for blood transfusion, and improved surgical techniques are the factors for increasing rate of the cesarean section. Mortality decreased considerably, but morbidity still remains as an important factor of concern. And that is an issue where we'll try to reduce the morbidity further. What is old? These are old, starting from Jack of New Fur, without knowledge of anatomy, then the fallopius, and the great surgeons who have started this surgery with the scientific background of anatomy. I think we salute today on the Teachers' Day on our ancestors of surgeons. Now, coming to the evolution of cesarean section meant different things to different people at different times. Now, one at the time when vaginal delivery at all costs. But in the second, vaginal delivery at whose cost? Whether than the cost of the mother, whether the cost of the child? No. And there are some extremist people who says that why vaginal birth at all? It is one-way traffic. The sperm should enter to the vagina and the baby should come out through the other route, not through the same route for that. This is a philosophy of extremist gynecologist, a terroristic obstetrician. And my teacher, D.K. Patnaik, always tells, man delivers abdominally, God delivers vaginally. If the patient has come and they delivered it, God has delivered it, it's okay. But if you have come and consulted you, knife is the answer for that. And again, I'll tell that this is a terroristic obstetrician's view. So that the meaning of cesarean, different things to different people at different times for them. Now coming to the indications which I was telling, these are broad indications. We cannot say that all pregnancy will be terminated by cesarean. I cannot accept in the present status for that. Though we have increased the rate of cesarean section for them. It's not that all patients cesarean for all, I can't accept. And therefore, the main indications comes in dystocia. Second important is suspected fetal compromise. Fetal compromise, gone are that area where the maternal interest is the first and fourth thing, ignoring the fetus. Now we have reached a stage where fetus has achieved the status of a second patient. We cannot ignore, and therefore a conscious decision has to be given, balancing both the mother and the fetus for that. And fetal compromise with the technological aids, we are yet to find out what is the status of fetus. It's very difficult to find out the fetal status in the present era of electronic gadgets and computerized gadgets available, even CTG, even ultrasound, even color Doppler, even the acid-base balance of estimating the pH of the fetus. We are not in a position to find out what is the fetal status for them. I am dreaming that in future a fetal sensor should be there. In the era of computer technology and electronic technology, you just apply that sensor and fetus will tell, fetus will give an alarm, doctor, you deliver me, keep me out, my life is 4 hours, my life is 24 hours, and that is my dream. Maybe that I'm wishing for that sensor to come out, when that will come true. Malpresentation is another indication where we know that in a transverse lie, in a bridge presentations, these are all factors for that. Most important indication is a prior cesarean birth. Now, gone are the era where one cesarean section is not always cesarean section, but 2 cesarean section above, always a cesarean section. So repeat section now, a prior cesarean birth is always responsible for again increasing the rate of cesarean section. This is one of the indications, but prior cesarean section, single cesarean, there is a place for trial vaginal delivery, which I will just narrate. Of course, it revolves around controversies. Other indications are placental disorders, like placenta previa and abruption, multifetal gestation, fetal disease. The fetal component absolutely is important, and maternal, medical and physiological change. A preeclampsia, a disease which endangers the mother life. I think these are all indications for cesarean section. These are key issues. There is a rising trend globally and nationally about them. There is a lot of debates. Is there a need to decline for a decline in the rising trend? I think you know the cause of rising trend. Maybe technical, maybe fetal, maybe a medico-legal, maybe cesarean section in demand and a previous cesarean section repeat. There is a rise in rate trend of cesarean section. But is there a need for decline? There is a serious concern and a debate which is there. Now for quite many years in repeat section, the 2 lakh or vaginal birth after cesarean section was advocated for that. In 25 to 30% of the cases, it becomes successful, but it is a short-term benefit for that. Now, VBAC is again coming to the controversial aspect for that. So therefore, that has to be considered as a debatable stage, and controversial stay further. So in this context, most important I will address about the critical issues in the operative technique. Because it's a session of surgical, I think session of skill development, I will give more importance to the critical issues in the operative techniques and what are the changes for that. So these are changing trends and techniques. Before the real video presentations, I will just touch these particular points. All of you are doing cesarean section. Just think about you. Think about these factors, what are you doing it? And you will be an excellent surgeon and dedicated and safe cesarean section you can do it. First important thing, nobody considers, everybody wants to be a surgeon and without little thinking about pre-op assessment and planning. We are bad in pre-operative planning. I think that's absolutely important. Pre-operative assessment and planning is absolutely important. Many of the surgeons, they then and there decide what is to be there. But that is absolutely wrong. A mindset should be there. Each case is different. In each case, you analyze yourself before putting a knife. What is this particular case? What are the problems I am likely to encounter? And be mentally prepared for that, and mindset should be there rather than seeing the complications, seeing that, and then decision making is done. And therefore, a good surgeon should have an appropriate planning, surgical planning and assessment for that. Simple example I am giving you. I have seen in my life patient presenting with, say, transverse lie. How to deliver the baby? Then they immediately, without a surgical planning, they do the same procedure, insert their hand after incising the uterus and just blindly bring out a hand. Instead of bringing out a leg, they bring out a hand. And then they push it and then a lot of difficulties there. This is only because they are not having a pre-op assessment and planning. Had you been a pre-op assessment, where is the head and where is the leg? You directly introduce your hand to the leg side and bringing down the foot for that. So this is a small example. In every technique, I think the planning is important. If there is a previous sections, 2 or 3, you must be very, very meticulous about the bladder and all that. You expect that this is a problem and prepare yourself for that planning. Second important aspect is the choice of anesthesia and anesthetic techniques. Now, why? It is purely the job of the anesthetist. But remember, we are the worst sufferer as far as the medico-legal problem. We depend on anesthetist and the pediatrician, but the whole burden is on you. The patient knows you, not the anesthetist, neither the pediatrician. And therefore, any problem arising out of anesthesia, the surgeon has to be blamed for it. And therefore, we have some role in the choice of anesthesia, and we should know something about the choice of anesthesia. And out of all studies, scientific evidence says that the choice of anesthesia in cesarean section is a regional anesthesia. And therefore, regional is always better, even with high-risk cases. Like one other time, when in eclampsia and severe preeclampsia, for quite a small few years, it was general anesthesia. Now everybody is convinced that even with that eclampsia, regional anesthesia is the best. Now, there was a time when epidural was very, very favorable for that because there was not change in blood pressure. Now with the small needle, with the competent anesthetist, with the monitoring, even spinal anesthesia is the best for that. But ultimately, maybe spinal, maybe epidural. The choice of anesthesia, the first and foremost priority is a regional anesthesia, there is no doubt about it. Then comes the abdominal entry. Abdominal entry, the choice of incision. We have seen the evolution, our teachers and great grand teachers we have seen. At that time, the only laparotomy is a paramedian incision. Then came the median incision, longitudinal incision. Then of course, now we are convinced that a transverse incision, a suprapubic incision is the choice of incision. Out of the suprapubic incision, there are various types of incision, like a Maillard, like a Cherny, like a fun and still or a modified fun and still, and of course the Joel Cohen incision. Now, the modified fun and still has been accepted as the best form that, but suprapubic transverse, no longitudinal incision unless a patient, the surgeon is not very competent about it. So abdominal entry, the choice of incision is always a suprapubic and fun and still. Uterine incision, always a lower segment incision, except in barring a few instances of classical, there is no era of classical section. I have in my life, I have never done a classical incision for that. And uterine incision is always a lower segment transverse. Maybe in few cases, you can do a lower segment longitudinal incision, but lower segment transverse is the commonest. The care incision which is there, that is lower segment transverse, and oblique, I think carved incision to avoid the uterine is a standard technique. Excepting in the cases where the lower segment is not well formed, and that cases the chronic incision, lower segment longitudinal is there. But extension of the longitudinal incision upwards is not a scientific method for that also. Converting into that. And worst is the T-shaped incision. I will just abandon the T-shaped incision which anybody is giving now or not. I'm not sure, but abandon that procedure for them. Now, mode of delivery is very, very important. Is the mode of delivery of the baby. It depends on the presentation. Majority of the cases are head. The head may be very low. The head may be mid. Head may be high up, floating head. Or there could be transverse. There could be bridge, and there could be placenta previa. There could be lower segment myoma and all that. Mode of delivery is important because there the problem of extension of the injuries, extension of the wound laterally occurs, colporesis occurs, and lot of problems occurs to the fetus also. So mode of delivery, safe delivery of the baby is important. I will show you in my videos. Choice of ecbolics. Once upon a time, we were routinely using the ergometrin for that. So after the active management of third stage of labor, importance is given to the oxytocin. Choice of ecbolics is oxytocin, oxytocin, and oxytocin, and you give 10 units of oxytocin intramuscular and 10 units to the drip. But remember, the timing is important. Within 60 seconds or 1 minute of delivery of the head, I think that should be completed for that. If you give late also, the uterus will not contract. I think that choice of ecbolics is absolutely important. And in some cases where we anticipate PPH, you can use the prostaglandins and or symptometrin for that also. But primarily the oxytocin is important. Method of placental delivery. People are very hasty. They look into the time and did the cesarean section. Be refrain from that. Somebody says that I am doing with 28 minutes. Another person says that I am doing with 18 minutes. The time is not important. At the risk of the patient, you are delivering it? No. I think undue delay is important, is not recommended. And doing very hastily, keeping in the watch is not recommended for that also. And therefore, you wait, deliver the baby, and then hand over to the pediatrician. And don't do a manual removal of the placenta always. People have a habit of finishing quickly. They will land in PPH. And then creation and all sorts of problems of the hemostatic suture, the internal ligation, the compression suture, and then hysterectomy also. You create, it's my feeling that cesarean section, cesarean hysterectomy, due to PPH, barring the morbid adhesion of placenta, hysterectomy, majority of the hysterectomy is done for iatrogenic reasons. You create PPH, and this is one method where you allow the uterus to contract after ecbolics, and the whole placenta will be separating automatically, and then living ligature will be seeing at the end that everything will be bloodless for that. Then the uterine closure. Lot of controversy arises about the uterine closure, about the material, about how you close it, single layer, double layer, everything for that. And that is revolving around a lot of controversy after the other methods, newer methods and techniques with evidence base is there for that. Peritoneal closure. Now that has been accepted that peritoneum will unite, there is no need of peritoneal closure for that. That is accepted, evidence base is there. But remember that peritoneal closure, if you are not given, see for the vessels, see for whether there is a bleeding vessels, hemostasis in the peritoneal edges for that. That's absolutely mandatory. Then of course abdominal closure and seeing for the hemostasis, every step you find out for that, and abdominal closure is completed for that. Now you can do a concomitant surgical procedure. Like if there is an ovarian cyst, you can do it. Like common is the myomectomy, cesarean myomectomy. And that's a very common thing. And I am crazy of doing cesarean myomectomy. And for last so many years, I'm used to do that. And I don't consider that if there is a myoma, there will be PPH and you avoid that. If it is a surgically, I think you have to remove it, the size of the myoma, not about the small size myoma. If it is an upper, I think the surgery is necessary for that. Even if a big myoma, you remove at the same sitting. That will give a lot of benefit to the patient as well as to you also. And therefore, concomitant surgical. Intentionally, today I have projected one of my videos where I am doing a cesarean section with a myoma, showing how to do a cesarean and how to do a cesarean myomectomy also. And of course, the future, again I have said, that future is something different, and whether the role of cesarean will be there or not, endoscopy has evolved around gynecology subject in many aspects, accepting obstetric practice, the cesarean section. I think endoscopy, you cannot deliver the baby by endoscope. Maybe that in future, when you enchant a mantra, it can be there for that. Because always the science and the mythology, if you correlate with that, where from endoscopy came, the concept of endoscopy, I think the water's reflection of Arjun and then firing it, and that is simulating with endoscopy. You look at another space and look at the screen and do the disease, and you look at the Hanuman's philosophy of minimizing and maximizing. When the philosophy of minimizing and maximizing comes, and therefore you enchant a mantra, 3 kg baby will be reduced to 3 millimeter. You shock it out through hysteroscope and then enchant a mantra, maximize it to 3 kg and hand over to the couple. Then only is possible. Otherwise, it's not possible for them. Now, sporadically reported throughout medical history, cesarean birth has only been during the last century been technically refined and rendered safe for both mother and fetus. Salute to the technology and techniques for that. So a brief thing about the rising trend. Why the rising trend? Safety of lower uterine segment technique is one of the reasons. Evolution of anesthetic proficiency, availability of blood products and antibiotics, broadening of indications. Indications have broadened. Cesarean section on demand, defensive obstetric practice. These are all factors, medico-legal purpose. Recognition of fetus as a second patient, this is important. Women's choice, maternal autonomy, this is important. Way back during 2004, there was a British Medical Journal article where I found that in London, at that time, the rate of 32.9% of the female obstetricians themselves, they wanted cesarean section unindicated. There was no indication, but 32.9% of the female obstetricians opted for cesarean sections. This signifies that if the obstetricians themselves want it, why not the other patients for that? So women's choice has been given a maternal autonomy. So cesarean section on demand is another reason for increasing trend. Medico-legal concern like defensive obstetric practice, alteration in parental and societal expectations of pregnancy outcome. Pregnancy outcome, that is important. Changing obstetric training, we teachers are responsible. Now, I will dream of the future years where The postgraduates will be eager to see one vaginal delivery because they are always doing cesarean section. The changing obstetric training, the art of obstetrics, the delivery by vaginal route, the instrumental delivery, I think that is also responsible for them. And lastly, adversity of vaginal birth. Vaginal birth at all cost, at the cost of the mother. You know the pelvic floor relaxation occurs. You know the fecal problem occurs. You know the retention, the urinary problem occurs. All these are adversities of vaginal birth. The morbidity is important. Sexual dysfunction is related to that. And therefore, that is again a cause for the increasing incidence. Is there a need to reduce the incidence of cesarean birth? Lack of RCT, Hippocratic obstetric practice, that is responsible. For a VVIPs, you do short to the cesarean section. For an uneducated, illiterate women, why practice for vaginal delivery? VBS is a short-term, short-lived procedure. There are benefits versus risk analysis for that. Post-cesarean issues, declining fertility and pregnancy wastage, placental problem, intra-placental problem in form of adhesions, morbidly adherent placenta and low-lying placenta, intraoperative problem, VBS and future gynecological manifestations and issues. Now, the gynecologists who have forgotten the obstetric practice, they are now only doing the gynecology. Say, for example, in a previous cesarean doing a hysterectomy by vaginal route. How to do that? Manifestation issues will come for that, and a lateral window is now accepted for it. So, therefore, optimizing techniques of cesarean section is a need. Decreasing in mortality, still further decrease in morbidity, and we must standardize the procedure. There can say that my technique, always forget about it. Everybody will develop that this is my technique. I do not believe in I believe in we. I is illness, we is wellness. Evidence-based medicine, of course, will be there in the scientific aspects, changing status, changing techniques, but ultimately a uniformity, acceptability, safety part is important. And therefore, you do a technique, you acquire your skill where the safety is important for them. So therefore, thinking about it, I said one thing, there are innumerable operators in the globe, but very few surgeons. So just think about and analyze who is an operator and who is a surgeon. Don't try to be an operator, try to be a surgeon. And the purpose of this particular E-Gurukul and onwards, I am planning to transform operators to surgeons for that also. And that I do not know whether I will be possible or not, but I will try to make it. Now, these are some critical issues in operative technique. I have already told this about the choice of anesthesia is regional. Abdominal entry, choice of incision is always suprapubic, but which incision that you adopt? Uterine incision is always a lower segment transverse. Mode of delivery, still many people are using the different techniques of a manual, but instrument can help you, like the forceps, like the vacuum. Choice of aqualis, I still recommend the oxytocin, and if there is a PPH, you can add to, or risk of PPH, you can add to prostaglandins. Method of placenta delivery, I will always say pack, press and pray. You have delivered the baby, don't be in a hurry. Give aquabolics, and there you require a mop. Don't use mop from the beginning. Our teachers were telling that mop is necessary because to avoid soiling for that. But remember, mop will be a future problem, both medical legal problem will occur. And we're forgetting the mop for that also. And I always preach more of suction, don't put mop. But here, after delivery of the baby, with a mop, you pack it over the lower uterine segment in front. Don't pack inside the paracolic gutter, but you pack it over it in the middle part, over the uterus where you have given incision. And pack, press and pray, 3 P's. I think by that time, the placenta will separate automatically, and absolutely clean cut incision without bleeding, and nice surgery you can do it. Remember, pack, press and pray. And then you practice it, and then you can remember the 4th P, PC Mahapatra for that. So repair, Now the problem occurs, the controversy about the single layer, double layer. I think I remember single layer surgery. I remember my age-old days when I was new just after passing the MD. I was posted in a peripheral hospital in a CHC. I had no idea on the single layer surgery. But accidentally, one patient I remember that the anesthesia was given, and all of a sudden there was a problem of hypotension, and then resuscitated. And earlier, just in the midway, I found that the patient is having hypotension and it is about to go for a cardiac arrest. Then immediately I sutured in one layer and saved the patient without knowing the concept of single layer way back in 1980s. Now when single layer came, the concept of single layer, then I was not very much convinced about the possibility of the tensile strength of the suture, integrity of that, what will be the suture, if at all we are going for a vaginal delivery in the subsequent. I was little skeptical, and therefore after doing few cases, I was not very much convinced. I reverted back to double layer when people still propose for single layer suture for that. They save time. They save additional 5-10 minutes time, but I was always in favor of double layer for that also. And now I find that all evidences come that double layer is better than single layer, because the scar distance will be more if the single layer is given for that. Of course, it's a choice of decision, but the double layer is accepted now as the type of suture material. But I will insist that type of suture material, the integrity of the scar is much better when less amount weight of the suture material is less. So therefore, thinner the suture material, it is always best. And of course, if you are giving a vicryl synthetic suture material, the maximum you can use up to 10. But previously we were taught, and majority of the people now use number 1. If number 1 is given, more weight of the suture material is incorporated in the scar, which is going to affect that. And therefore, I will just recommend that even with the 1 0, not more than that, even with the 2 0, with a 35 mm needle is also manageable for that. But 1 0, so that the less of suture material will be there for that also. Type of suture material. Exteriorization, benefits and this. If you exteriorize the uterus, the benefits are there that you can see, and more commonly when there is an extension, you can do very well. And with the assistance LS, you can do much better for that. But the risk is that the incidence of infection, if the vomiting is more, the vagal problem will be there, hypotension will be there. All these are benefits and risks of the exteriorization. Peritoneal closure, I have already told, peritoneal closure versus non-closure. If the peritoneum is clean, there is one agreement is that when you are doing a peritoneal closure, the bladder will be lifted out. I don't agree with that. If you are doing a proper closure, age to age, why the bladder will be lifted? If we are keeping the lower edge of the peritoneum and stitching it to the fundus, then the bladder will be lifted off. But don't recommend that. But at the same time, I find in repeat sections or in cases, if you are leaving the peritoneum, no problem. But remember that there is no bleeding points in the age of the vessels. I have seen few cases where because of the bleeding from the peritoneum, massive hemaperitoneum occurs in postoperative period. So therefore, if at all you are leaving it, and see for the hemostasis for that. Skin closure technique, either you can go for a subacute or you can go for the mattress. That is the choice is yours for that. So choice of anesthesia, again I will repeat, the general versus regional. Regional is the best. Now, if at all you are giving a general anesthesia, one point I will tell that people use the general anesthesia, and the recommendation is that you have to deliver it quickly, so that transverse incision is not recommended for that. No. The recovery, I think, that is going to be affected, even with the transverse also. Don't be hasty in delivery. Because if you are giving a pentothal, the recirculation time is 6 minutes. If we are going to deliver within 10 minutes, 2 minutes, it's all right. Otherwise, you deliver within after 6 minutes. That is no problem. If you deliver within 2 to 6 minutes hurried, then the fetus will be depressed for that. So remember, if at all the general anesthesia are given, go slow, even transverse incision, deliver it after 6 minutes, no problem. And usually that will happen with transverse incision. So the incision delivery interval, if it is a regional, if it is a general anesthesia, don't think that I will deliver it by giving a longitudinal incision for that. Pre-op assessment and planning, I know that clinical profile, need for investigations, need for ancillary persons, pre-anesthetic evaluation. I think this is important. Need for investigation, anemia, if there is hemoglobin, and some other cases investigation. Need for ancillary persons, you keep a surgeon's presence also if there is needed. Pre-anesthetic evaluation has to be done in that particular case. So the overall pre-op assessment and planning, a mindset and a surgical planning is necessary for that. Abdominal entry, then comes to the abdominal entry. Choice of skin incision, transfers, the Funnenstiel is accepted. Maillard is a big incision and Joel Cohen is a higher level incision for that also. Therefore, Maillard is a muscle cutting incision. I think muscle splitting incision and Funnenstiel is the best. But the length of the incision should be is also important for that. Length of the incision should be adequate for the delivery of the baby, not too large to have an aesthetic sense for that. So 15 centimeter is a standard incision, length of incision for that also. And longitudinal, don't is as far as possible, we try to avoid longitudinal. And earlier paramedian was supposed to be the best. Now it is proved that midline, if at all longitudinal, midline is the best. No role for paramedian for that also. And as far as possible, transfers. People say that if there is a previous cesarean longitudinal incision, I will go for a longitudinal incision. I think it's contrary to that. You give a transverse incision, the chance of hernia will be less. Even if there is a longitudinal incision, you go for a transverse, the hernia will be more dangerous than the aesthetic part for that. And therefore, giving a transverse in a previous longitudinal also, there is no problem as far as the prevention of hernia is concerned for that. Hemostasis, whatever the things you do, hemostasis for that. And of course, in difficult situations, abdominal entry, particularly in previous repeat sections, there will be completely adhesions for that. In difficult situations, we'll discuss subsequently in the subsequent session. Uterine incision, I have told, low transverse, merits versus demerits. Low transverse, there is a merits that it is a lying in the lower uterine segment. Transverse, the chances of scar rupture is less. But the demerits is that there may be the extension to the uterine and bleeding from the angle for that. And therefore, you give a little carved incision on either side. Low vertical merits and demerits. Where will we low vertical? Only in those cases where the lower segment is not formed as a tubular, you can give it. But the demerits is that there is likelihood of extension to the upper segment. And classical, in no way I will recommend that. SERP versus blunt dissection. By SERP dissection, you can use the scissor to have a SERP and blunt dissection. The advantage of blunt dissection, only one advantage is that you are doing a lacerated injury and it bleeds less. Second important, the chances of uterine artery involvement in the angle is less because you are just creeping it. But at the same time, incision, lacerated injury are inferior to the clean cut suture. And by seizure, you can give a carved incision to avoid the uterine for that also. And that is much better. And SERP versus blunt dissection, I think SERP dissection is always good. And of course, in difficult situations, if there are vessels, you tie proximal and distally. If there is a placenta, you go through the placenta. If there is a tumor, you can remove the myoma and then do it. If there is a scar, I think that's the important point. Over the scar, below the scar, or above the scar for that also. And over the scar, there is not a problem. You just give it. If there is a fibrosis, you can excise the scar and then suture it. And malpresentations also, there is a problem for that. Mode of delivery of the baby. Method of disinfection. If there is a deeply engaged head, the method of disinfection We know either you can ask your assistant to push it, disinfect, or do the maneuver, and remember the maneuver accepted for that, and that you can do it for that. The conventional gymnastics versus instrumental aid. I think normally most of the people do the cesarean and deliver it with the hand, and they apply the hand, ask the assistant to push the fundal pressure. They fail. They ask the assistant, ask the anesthetist, the pharmacist, and everybody, and it becomes really a gymnastics in the OT. So therefore, you add the different aids are either a forceps or a vacuum. I will show the vacuum is much better than the forceps. And these earlier were using the vacuum, but we do not know whether you will give a correct application for that. And therefore, the vacuum is always the best instrument which is there for that. And I used to teach all my students for last 20 years. I'm using the vacuum, high head, low head, and mid head. If that all the head is there, you apply the vacuum. And if there's a deeply engaged head, you disinfect it and then use it with that. And need for breech extraction. If there's a breech or a transverse, you can do a breech extraction for that. Choice of ecbolics, I've already told oxytocin, and if necessary, prostaglandins for that. Delivery of the afterwards, always slow delivery, placental delivery, and don't look at your watch and don't do manual removal of the placenta unless it's an adherent placenta for that. And morbidly and the simple adhesion for that. Exploration of the cavity. Don't try to have a aggressive and a very drastic exploration of the cavity to find out for that. You do a delivery of the baby, spontaneous expulsion, and exploration will not be necessary. Need for cervical dilatation. Many people do and put a dilator for cervical dilatation. No, it's not necessary. The drainage will be absolutely normal. And if at all, you apply your own index finger for that. Repair, extrusion versus in situ repair, I have clarified. Choice is yours. Single layer versus double layer. Still, I don't blame the persons who are doing a single layer, but double layer evidence says the double layer. Type of suture material, I think the synthetic suture, the long, I think the delayed absorbable suture material like Vicryl is much better. You can use the catgut also, but suture, if at all, whatever suture material you use it, don't use more than 1 Peritoneal closure versus non-closure, the choice is yours. Meticulous technique versus complacency. Hemostasis. Don't be complacent. A meticulous technique must be used. Massage the uterus versus kissing. Many people have a habit of massaging the uterus. I think be gentle on the uterus. You know that females are very delicate, and uterus, don't massage the uterus. Have a kissing part for that, and that is important. And skin closure, muscle apposition, you do a rectus sheath, you see rectus muscle, the under surface of the muscle you see, and before closure, because there could be a small bleeding points below the muscle, and that is a small point for that, hemostasis. And rectus sheath, you use it with the continuous suture or interrupted, whatever you choose. Muscle apposition, of course, the muscle apposition has to be there. Many people leave the muscle, but not too tight a muscle apposition, just oppose the muscle. Otherwise, the repeat section, you will find the rectus sheath is densely adherent to the peritoneum, and that becomes a problem. Muscle apposition is not a problem. And skin closure, choice is yours for that. Complication, hemorrhage, UTI, GI functions, respiratory complications, thromboembolic, infection, and others. I don't want to go into the details for that. Concomitant procedure, I have already told. Sterilization, ovarian pathology. If there is an ovarian tumor, you can do it. Cesarean myomectomy, which is a controversial. Purposefully, I will show you how to do a cesarean myomectomy. You can do an appendicectomy also, and other surgeries for that. Now, future, I have already told about the endoscopic modality. Maybe a theory, but maybe that it could be a practice. Or the alternative, deviating the uterine monopoly for childbirth and looking for alternative receptacle for that. That's really a fantasy for that. And can I have a video for that? Can I have a video presentation? Can I have a video presentation? Can I start my video?
Just a minute.
Can I start? Yeah. Just you see how the delivery of that, the same suprapubic incision, the transverse incision has been given, and now the delivery of the head. The head is there. This is the very important vacuum, elastic vacuum, not metallic vacuum. You apply it half to the head and half to the muscle. And with the finger, you just rotate it so that the whole of the cup will engulf the whole of the head. And apply the middle-sized vacuum, elastic vacuum, and clearly you can avoid the gymnastics in the OT for that. Remember, even without a fundal pressure, the head is being delivered very smoothly. That will have an advantage of avoiding this. Now, after delivery, before the suturing, I find this is a case of a large myoma uterus in the posterior surface. Now, this is a technique which I will show you, that don't do a myomectomy outside. You do an intracavitary myomectomy. I'm going for this intracavitary myomectomy. Before suturing the uterine layer, I incise the posterior aspect and through the cavity, just enucleating with the help of the myoma screw, and such a big myoma, you try to go for a proper cleavage area, and the whole of the myoma, if you are going to the proper cleavage, the myoma can be delivered, myomectomy can be done very well. The advantage of this particular procedure is that the bleeding will be less, and as soon as you remove the whole of the myoma, the dead space will be very, very minimum, so that just suture it and you can just have a hemostatic closure for that also. Don't have to go for an outside separate incision, and that will cause more of bleeding. That will be really difficult to close for that also. And this is very, very important. And for more than 1 decade, I am doing this type of cesarean myomectomy, excepting the subserous myoma. All myomas, irrespective of the size, can be delivered, excepting a subserous and a very high fundal myoma. That is not possible. Otherwise, with a retractor, you can find out where is the location, the anterior and posterior, then you can use it. And after that, you find whole of the big space has been reduced to a very small space. When the uterus gets contracted and the bleeding will be least, you excise the redundant portion and you can find the bed. Clearly the bed is visible, and you can go for a suturing for that, either a continuous or an interrupted, but a good hemostatic closure with the closure of the dead space for that. And this will eliminate the bleeding. That will eliminate really the future chances of adhesion formation for that also. This is the beautiful technique of intracavitary myomectomy, which I always say and always do, excepting a subserous myoma or a deep fundal myoma. Otherwise, it's easier. It's not very difficult. You retract through the cesarean wound, you retract with the instruments and find out where is the myoma, give an incision, and with the myoma screw, you deliver it, and that becomes very, very easy for that also. And that really becomes very satisfactory to the surgeon as well as to the patients also for that. And this, you can go for either a interrupted suture or a continuous double layer, triple layer, whatever it may be. But hemostasis has to be given utmost importance for that. And that is the procedure which you do it. And then you start from the uterine incision. Remember, the uterine incision, the first time, both the angles has to be sutured first. And remember, many people use the angle, use the Ellis forceps to the angle. But I recommend that 2 Ellis forceps on either side, and you find the V shape, the angle you can see it, rather than holding the angle with this Ellis forceps. By that, what will happen? It will be a dog-like ear which will be there for that. The first layer after that, the second layer is given for that, and second layer you can go for a Lambert suture, and then the peritoneum. I think this is the peritoneum which is given it, both visceral as well as the parietal peritoneum is given in this particular case. I always recommend, this is my technique that I always go for that. The choice is yours. I say that you can avoid it, but remember, suture material is 1-0, and you secure the angle first, your own side angle, do it first, then start from the other angle for that. And therefore, if you good hemostasis, securing the angle. Don't have a mop for that, more of suction for that. It will be really nice to have that. And that finishes the whole procedure. And as usual, you use the layer technique. You close the, oppose the muscle, and then the rectus sheath and the skin, either a soft cuticular or a mattress, whichever you like it, and the choice is yours for that. Thank you very much, ladies and gentlemen, and thank you, my viewers. This is one of the exemplary, and I think there are many, many hidden talents which is there across the country. I've given a small sample for that also. With all humility, I can say that you are all doing day and night, day in and day out. I've given one of the sample and one of my own views. I've done a lot of mistakes. I've learned from many of the mistakes, which in the next session, after 2 weeks, the next session will be solving clinical dilemmas related to cesarean section only. So the whole topic of cesarean section will be covered, and I hope I have given one particular example, and maybe that this is my personal view for that, but don't follow me. You practice. If it is satisfactory to you, then follow for that. Don't be evidence-based. Many people are telling evidence-based, these are good and all that. You are confused with that. And believe me, the people who practice, the people who publish, they don't work. Those who work do not publish. Because those who work do not have a time to think. And those who publish with the air-conditioned room, with this laptop, with 15 minutes, they can publish 50 articles for that also. So you are the best judge. You are working day and night. When the clinicians will do a publication, you acquire a knowledge, you identify the different literatures and acquire a knowledge, new techniques, observe the different surgeons. Don't follow me. I am one of them. I think you follow varieties. There are innumerable better surgeons than me, better techniques than me, and just mix and match, synthesize, and for the benefit of the patient, safety first. Thank you very much, ladies and gentlemen, and my viewer. And I'm indebted to Juventus Pharma and Mr. PK Guha, Alad, Diwan, and many, many others who are really brain behind this Gurukul program. I don't know whether I've done wonders or not, but I've done my job. With all humility, I can tell that I want a feedback for that. And we'll continue to do that in subsequent sitting for that. And if the feedback is good, we will continue. Otherwise, we'll reject it for that. Thank you very much.
Sir, thank you so much for such a wonderful lecture. And you have kept us spellbound. Like, I'm sure all the audience is also very, very keen to listen further to you. But now, because of paucity of time, we would like to go to the next level, and where, we have given an option to allow some of the guys or attending doctors to come live on stage.
Yeah, that's very good. And we have got 20 minutes also, we can have an interaction.
Yeah. And sir, moreover, there are huge number of questions people have asked. Yeah. And we would like to, put all those questions in front of you one by one. Yeah.
I will try my best. I will try my best to solve this. And if I cannot solve it, I will say no, I can't.
Yes, sure, sir. So, sir, I'll first put Dr. Alka Dhirendra. I'm just allowing her to come on stage. So I don't know if she's available at this moment, because this is a bit of mismatch. And meanwhile, I'll start.
Because already on previous webinars, I find a lot of chats. Yeah. And I think I want to see them live. And I'll be very happy to see my fellows on live and talk to them. This will simulate physical rather than digital.
Yeah. So in fact, there is Dr. Suniti, Dr. Alka Dhirendra, Dr. Sushila. I have admitted them in, but I don't know whether they are able to, join. Dr. Nivedita Pal is there. In the meanwhile, sir, by the time they connect to us,
any questions in chat I can answer.
I'll start with a few of the questions, sir. So one question from Dr. Ranjana Jha is there. If anticipating PPH, why not ergometrin? And have you come across any complications using ergometrin?
Well, we were using ergometrin long before, about 20 years back, we were using the long, I think, ergometrin routinely, even for normal delivery also. But the problem is there are absolute contraindication. We see that yes, PIH is one of the contraindications, RH is another relative contraindication, but we can use it. There is not a problem for that. Transient hypertension could be there, but invariably vomiting is there for that, ergometrin. And remember, if you compare ergometrin with the oxytocin, ergometrin is a better styptic than the oxytocin for that. And more so, earlier it was told that ergometrin is one of the demerits of ergometrin is the effectivity, because it's a heat labile, and therefore heat labile ergometrin, oxytocin is not heat labile, but now subsequently say that oxytocin is also heat labile for that. After recommendation of the WHO for active management of labor, over the years, my practice, I say that yes, invariably oxytocin is absolutely good. Don't give much of drugs for that. Where you anticipate PPH, I think instead of ergometrin, prostaglandin is the strongest uterine tonic contraction. I think in that case, you have better devote attention to the prostaglandins.
Right.
But ergometrin can be given. That's no problem.
That explains a lot, sir. Sir, there is another query which is coming from Dr. Uma Devi. She's saying that if you can just comment on Misgav-Ladakh technique slightly.
Yeah. Misgav-Ladakh technique has different components. Misgav-Ladakh technique starting from the incision, the Joel Cohen incision, then just nick it and strip the uterine, I think the rectus sheath. It's not cutting, but stripping it. Peritoneum, just strip it, and you can enter it very fast. That's important, and bleeding will be less. That's absolutely. Sure. That's one component. Second component is single layer closure. Third component, no peritoneal closure. These are some of the important aspects of Misgav-Ladakh.
Right.
See, when Misgav-Ladakh came, I did about 50 cases. I followed it up. I didn't find any advantage out of it also.
Okay.
And that's why I am not used to that technique. And second philosophy, I was interacting, that we are not the healers. God is the healer. The layer in which we cut it, the same layer we must oppose. God is healing that. And third important, one of my fellow gynecologists say that I don't like Hiranyakashipu incision. Hiranyakashipu incision, the nursing avatar is not feasible. And lastly, for repeat section, there will be a problem for that. Right. So I use better a cautery and a Caesar, that is there. But I don't accept that, but there are a lot of evidences for Misgav-Ladakh for that also. But personally, I have used that. I have thrown away single layer technique. Joel coil incision is a long incision and a higher up incision where the pain is also more. Only thing I find that the stripping of the rectus sheath, I think in subsequent cesarean there will be a problem for that. So therefore, I have some limitations and skeptical about that.
Sure.
And revert back to my old techniques.
Sir, there is another interesting question. Now, this is from Dr. Rashmi. She's saying that how and what are the methods to reduce the isthmocele during closure?
Pardon?
How to reduce the isthmocele?
Oh, isthmocele regarding the closure of the suture. I think yes. Rasmi Hegde, I don't remember, one of my old student was Rasmi Hegde. Now she has become, I think, excelled me. She has become a teacher of mine. If that is Rasmi Hegde, I don't know.
She is in Bhubaneswar only, sir, actually.
Oh, Rasmi is my student then. Right. She has assisted me. She has assisted me in many of the cases for that. Lovely. And yeah, one of the very important factors, a good technique for suturing the uterus. Very important is the suturing in double layers, the isthmocele is less. Second important aspect, a very meticulous suturing is important. Earlier, we used to leave the decidua. Then there's a lot of studies that show that decidua, if you include it also, the chances of isthmosil is not as compared to leaving the decidua for that. But it should be absolutely, the closure should be absolutely like a plastic sense for that.
Okay.
Equal distance, equal thickness, and with the same tensile strength, you suture it. And isthmosil can be prevented for that also. Otherwise, the main is the technique of suturing a position with the plastic sense for that. So layer by layer, whatever you do it, I think people just close it as and when required and make this suture. Wherever you do a suture, if it is a U-shaped suture, you suture like a U-shape in equal distance, equal thickness with hemostasis. That will avoid isthmosil.
So that is the art of surgery, sir. So people are learning. Yeah, sure. Okay, sir. There is another question. That is there a role of classical section in accreta and increta?
Classical section in?
Is there a role of classical section in accreta and increta?
Yeah. I think you plan it earlier. I will go a little ahead. If there is a percreta, morbid adhesions and percreta and increta. Increta, there is not a problem. But increta, if there is a mild, simple adhesion, there is not a problem. But in morbid adhesions, particularly increta and percreta, there is an issue for that. And more so, when it is a repeat pregnancy, and she has earlier baby for that, barring primary gravida. I think if it is a percreta, invariably you have to resort to a cesarean hysterectomy. And those cases, you can do a classical remove it and do it. If you are decided for cesarean hysterectomy, you can do it for them. Otherwise, I don't recommend classical cesarean for everything for that also.
Right, sir. Right, sir. Okay, sir, there's a Dr. G. Jhansi. She's asking, like, any specific type of myoma is indication for CI, cesarean incision?
No, myoma by saying that myoma with pregnancy is not an indication for cesarean section, because majority of the big myomas also, they behave on uneventful pregnancy and spontaneous vaginal delivery also for them. If at all you are going for a cesarean for some other indication, in that particular case you can do it. The only thing, even I have seen in a big cervical myoma also, the delivery occurs spontaneously, I have seen for that. So wherever the cervical myoma is obstructing that, or it's a transverse lie with the cervical myoma, there you do a myomectomy and all that. And the myomectomy earlier, the indication was the subserous pedunculated myoma, the myoma over the line of incision. And these are the indications for myomectomy. Now, I broadened the indications, excepting a few cases where the size is small. There's no use removing a 1 centimeter, 2 centimeter, 3 centimeter and spoiling whole of the uterus for that. You leave it for that. But those myoma which is to be removed, which needs removal, must be removed at the same time. There is not a problem. And I give importance to intracavitary myomectomy rather than all these cases.
Okay, okay, great. Sir, there is Dr. Kavita Barnwal. Now she's asking, if placenta does not separate, then what to do?
Kavita, I have visited your OT. I think you are that. Kavita from Jamalpur, I think Bihar. It's a wonderful experience with you, with the OT and all that. Yeah. If the placenta is not expelled. Now, the only problem you find out, whether it's a simple adhesion or a more simple adhesion, it will be delivered. There is not a problem. You find out a cleavage and then deliver. Now, in a percreta or increta, the only thing where it's a primary gravida, age is young, these cases you want to have a save the uterus, conservative. And I have faced 2 cases of this particular case and 1 case of secondary abdominal pregnancy where I have removed the baby and kept the placenta, cut short the umbilical cord closer to the placenta and subsequently given methotrexate for that. There is only one case I have found out, but I have found a problem. Post-operative morbidity will be much more in that particular case.
Okay.
And if he sees a multiple issues, he's a multigravida, age is more, I think it's better that you do a hysterectomy for that also. I don't agree that ultimately you have to, many people are doing a hysterectomy, but the last resort is hysterectomy. They do all sorts of maneuver of PPH and all that. By the time they do it and lose the patient for that. If at all hysterectomy is there, in a case of Percita or Increta, I think it's better to do that, and without blood also you can do that rather than, if at all you want to conjure the uterus, it is an alternative for that. But remember the post-operative morbidity, infection and morbidity, fever and all that, infectious morbidity.
Sir, from Bhubaneswar, Dr. Niranjan Nayak, he's asking a question which I think you had tried to explain earlier also, that what is the best suture material for uterine closure?
I think Vicryl is the best. I think 10 is the best for that. But even 10, catgut can be used for that also. But I give more importance to the number of suture material. Thicker is better with the worse. The thinner, many people still use the number 1. I will discourage number 1 use. You can use the catgut, you can use the Vicryl. But Vicryl is supposed to be the best suture in all types of surgery for that. Because the delayed absorbable synthetic suture, the reactions are less.
Right, sir. Sir, there is a query from Agartala. This is Dr. Basudev Majumdar.
Yeah.
He's asking a very interesting question actually, sir. I think you pondered upon this a bit on earlier. Like, is parents' choice a valid indication for cesarean section?
It's not a valid, but it's not an invalid indication also. Because now in the era, see, I have seen the evolution of medical practice. Last 38 years I'm practicing gynecology. Once upon a time during my early phase, it was a prescriptive practice. Prescriptive practice means you advise that you take this drug, they will take it. The decision is cesarean, without any question they will accept that. This is a prescriptive practice. Then we have entered into another phase. It is a participatory practice. Whatever you say, you participate. You convince that cesarean is necessary because of these reasons and all that. You explain, counsel, and they will also ask questions. And after all, after participation, you reach it, whether you do a cesarean or do a vaginal labor. Now we have reached a stage, directive practice. Patients are directing us, sir, you do a hysterectomy, you do a cesarean for that also. So this is the evolution which I say. And in an era of medical legal, if the patient insists that you do, therefore, CSOD or cesarean section on demand has been accepted.
Okay.
Because if at all there is some problem, you will be in the court of law for that. And therefore, this patient's autonomy when it comes and cesarean section on demand, that is absolutely important for them. But that don't confuse it with the defensive obstetric practice. You do it to save your own skin. That is a different issue.
Right, sir. Okay, so there is another question coming from Mumbai. This is Dr. Dhaval saying that what is the way to overcome difficult extraction in LSCS of a transverse lie?
Yeah, that's what I told. First of all, the pre-op evaluation. You find out where is the head, on the left side or the right side. And the problem is in the transverse lie, the lower segment is not well formed. U-shaped incision is absolutely important. Lower segment U-shaped incision. Second important aspect is you have to deliver pulling out the leg. So beforehand you know that the leg is on the right side. You introduce the hand in the right side when some amount of liquor is there. Don't attempt. Delay is much worse for that. If all the liquor has been drained, and then it will be impossible. It's very difficult for that also. And grasp the leg. And obstetricians are very good in touch. They can feel, because 2 fingers we can sense where is the leg and where is the hand. We can discriminate where is the hand and where is the leg. Of course, with the same 5 and 5, and you remember that we are expert in touch, because we know, I can say one thing, that physicians say that they have got two brains. They can win the world by two brains. They can think anything in the world and win the world. Surgeons say that they have got two hands. They can undo and do anything in the world by the two hands. But gynecology, they believe that whole universe rests without two fingers. And with the two fingers, they can sense where is that. The touch sensation is more particularly for obstetricians. And they can feel the foot, and 1 foot at least they can grip it in the transverse lie, so that there is not a problem for that. Right. So right from the type of incision till delivery, early delivery, and pre-op planning is important. You can have no problem for that.
Right, sir. Sir, there is another question. I think you dwelled upon it just some time back regarding choice of the indication. Now, Dr. Saroj from Firozpur city of Punjab, she's saying that if there is indication for LSCS on demand in present scenario, can we write on our notes indication for LSCS on demand?
Yes, I will recommend CSOD, cesarean section on demand.
On demand. All right, sir. Okay, sir, there is another question which is coming from Koppal in Karnataka. Dr. Baswaraj Sajjan. The question is, how many times cesarean section can be repeated?
It depends on the patient, it depends on the surgeon. And time, we see that normally what happens, more than 3, many people say that 3 cesarean, if you're doing it, do it at sterilization. But if there is no issue, if all the previous 2 are dead, and this one is the 3rd which is living and we do not know the survival, exactly, we can try for the next. There is not a problem for that. Okay. And the skill, as the number of cesarean increases, the risk of the patient also increases. Okay. The skill is also important for the surgeon for that. And I don't think, if you go and compare particularly in Gulf countries, I have heard that they are going for 8th, 9th cesarean section. People, our Indian surgeons have done it for that.
Wow. Okay. That's nice. Okay, sir. There is another question that what is the measure to be taken to decrease adhesions in the CS? This is from Dr. Asma Memon from Krishnanagar, West Bengal.
Now, adhesions in human beings, there are 2 factors. One is a patient factor, another is a surgeon's factor. Patient factor is important because there are some patients, even if you do a very, very meticulous technique, the adhesions will be more. That you cannot know also. But majority or primarily, the technique is important.
Okay.
And therefore, a good technique with a gentle thing, with a good touch and a good tissue handling, I think you can reduce the cesarean to a much more better. And therefore, a hemostasis, if there is more of blooding and all that, adhesions will be there for that. If we are doing a gastric surgery, adhesions will be there. If we are not doing a proper handling of the tissues, and the adhesions will be more for that. So gentle to the tissue and a good technique is a majority of the cases you can avoid any adhesions for that also. Not that you are suturing the peritoneum, adhesion will be more. Leaving the peritoneum, adhesion will be. I don't accept that also.
Right. I earlier also said, sir, you are an artist and you have the art of doing cesarean section and reducing all the complications. So everybody wants to know from you that what you do actually, so that's a practical experience. So there is one more question coming in. That is from Bhubaneswar itself, Dr. Kalola Bej. The question is that how COVID status decides the mode of delivery in current scenario?
Current scenario, COVID pandemic is worse than fear pandemic. Fear pandemic has become more than COVID pandemic. And therefore, I always say that in COVID era, because of COVID positive, I think there are whatever studies have been there, the vertical transmission, there is absolutely no clear-cut evidence for that. And remember, because of COVID, it's an indication for cesarean, I don't accept that also. Wherever the vaginal delivery is possible, you go for that. Wherever cesarean is possible, neither cases it is more harmful for them.
Right. Okay, sir.
Maybe that more of studies will be going on, because in India also there are lot of cases of COVID positive delivered by our obstetricians in various parts for that. Let's have their feedback and then we can say what is the effect for that also.
Right, sir. Sir, now only couple of questions more. One is from Dr. Anjan Sarangi from Baripada. The question is, when to give oxytocin, before or after delivery of the head?
Well, this always you can give it before delivery. Say for example, if you are taking a long time of delivering the head, then there will be a problem of delivering the head. So therefore, the ideal recommendation is that as soon as you deliver the head, within 60 seconds you do it. You give it the oxytocin. Otherwise, it won't act. Delayed injection of oxytocin more than 1 minute will have no effect. I think PPH will be more important for that.
Right.
If at all you are giving when the head is inside and you can deliver it within 1 minute also, I think there is no problem. But if you are giving 5 minutes earlier to deliver the head, then there will be a problem for you.
Sir, as you earlier explained during your presentation about single or two-layer stitching, now this question is there from Dr. Rashmi Hegde again, that which is the preferred method, single or two-layer?
If you ask me, I will say that double layer is the method which I have always adopted for that, excepting in situations where there are repeat sections more than 3, where you are going for a tubal sterilization for that also, or very, very thin low uterine segment scar. There, single layer can be given for that also. Otherwise, double layer routinely I will prefer.
Right, sir. Sir, I am again putting back you on your slide itself, where you explained actually on the midline sections. Now, this question is coming from Dr. Deepa S. from Puducherry. She's asking, in previous midline skin incision, what is the incision of choice next time?
I have already explained that midline incision, if there is a previous midline incision, if there is a tendency that you give a midline incision, excision of the scar and give it, there as such the hernia will be more, because you are weakening the scar for that, and that is really a problem. So in that, if you try to avoid a hernia, it is better to use that transverse incision for that. Now the question comes, if there is a pre-existing hernia, there are few occasions where I have used hernia repair along with cesarean section. I think those cases, very few cases I have done it also, and wide scar, absolutely hernia is there, where mace has to be used for that. You can use it, but that is not recommended during pregnancy. The postoperative morbidity will be more also. It is better to do a transverse incision to prevent the hernia more often.
Right, sir. Sir, there is a question about Dr. M. Shivadhyal. The question is that, sir, at any time did you encounter atonic PPH in morbid adherence of the uterus to abdominal wall?
Pardon?
Dr. M. Shivadhyal is asking that, have you ever experienced or encountered atonic PPH in morbid adherence of the uterus to the abdominal wall?
Yeah. I have seen cases where morbidly adherent uterus to the abdominal wall. Abdominal wall, the previous cesarean, it is completely pasted to the abdominal wall. And there, more problem occurred with the entry. In that case, you lost all case. The altered anatomy is such that you cannot open the peritoneum. You have to, after the rectus, everything is pasted with that, and there is a difficulty in entry to the peritoneal cavity, where you may not be able to enter the peritoneal cavity directly to the uterus for that also, because it's a completely ventrofixed uterus for that.
Right.
If you analyze that particular case, why there will be atonic PPH there? Atonic PPH is not there in case of that. Rather, traumatic PPH will be more common in that. bleeding you take during incision, during delivery of the baby, because the anatomy is altered, there is more incidence of bleeding from incision side rather than atonic PPH. I will put it in that way. Bleeding could be more, and you can have a control on that. But atonic PPH is not more for that.
Right, sir.
Dr. Diwan, sir, Dr. Alka Kute is on stage if she wants to interview. Yeah,
Yeah, Alka, I have seen your face.
Yeah.
I have seen your face for, yeah, Alka, welcome. I can't hear you, Alka.
Guru Brahma, Guru Vishnu, Guru Devo Maheshwaraha, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namaha. It's a fantastic lecture. I remember Amravati's lecture on woman. You had given a fantastic lecture today also, sir.
Yeah.
And that also on Teachers' Day. It's my luck, sir. Thank you very much, sir.
I remember your active participation in Bhubaneswar, Elena
Yes,
Hospital by the pediatric people also.
Yes, sir. That was nice educational conference.
Thank you that you are enjoying.
Thank you, sir.
Thank you.
Gratitude to you.
Thank you.
So,
Yes, I wanted, Diwan. I want to see the face of my own lovable person.
yes, sir.
To see Alka, that in all webinars they give a chart.
Sure.
So I'm physically strong, digitally weak.
Yeah,
If
sir.
physical can be simulated with physical, nothing like it.
Absolutely, sir. We agree, sir. So that is our endeavor, sir, at this moment. And Aditya will guide us, like, if there is anybody else who is available online.
Sir, one question I wanted to ask. Can I ask, sir?
Yes,
Yeah.
Yes, sir. You just now you told about the demand, C-section on demand. But nowadays people are asking on muhurta, auspicious moment, like. So sometimes they can ask us to get it done at night, midnight, because that is good muhurta for the delivery of the fetus, delivery of the baby. So whether we should accept such demands, especially in today's era of medico-legal crisis. Very nowadays we are facing
If
medical
the
cases.
patient wants that I should do it at midnight at 2 a.m., you can hike your surgeon fees to 4 times. That I will go for that also and do that. There is not a problem for that.
Yeah, but sometimes complications are there, and at that time,
People have a faith. People have a faith. I have also seen many cases. But
Yes.
remember one thing. If it is not, I think, affecting the decision making, if it is not indicated, then don't do it. Suppose the patient is in labor
Yes.
and you find that the liquor is less and the fetus is going to be a jeopardy when we leave for a longer period. In that particular case, patients want that, yes, you want that immediately has to be done for the fetal sake. And they are telling that wait for 6 hours and then Shubha Muhurtam will come. By the time the baby will be done. Don't compromise that. Technical, if there is no technical, if you can defer it, then there is not a problem. Alka, I have one bad experience.
Yes.
The previous 2 cesarean section, elective cesarean was being decided.
Yeah.
First was a stillbirth. Second, I did it and there was a daughter. And third pregnancy was second infertility conceived following hysteroscopic cannulation. So whole duration of the third pregnancy, it was continuing. She is a VIP.
Okay.
And I decided for a cesarean section on, say, 20th of July. The place is fixed, the nursing home is fixed. I had to go to Bhubaneswar and do that. I obliged for that and decided that on 20th that should be done. On 18th it should be done. Then she agreed, and later on the mother-in-law came. Sir, we have asked our Baba, the Shubha Muhurtam is not on 18th, you do it on 20th.
Yes, difficult.
Do it on 20th. I find there is no, the patient is normotensive, it was a 38 weeks, shifting for 2 days is not at all a problem for that. So there is no technical hindrance for that. So he agreed for that. Believe me, on 19th, patient had a spotting, small spotting, and entered into the hospital and fetal heart was absent.
Very
And
difficult.
I had to do that, and it was a true knot. It was a true knot. Absolutely plenty of liker, baby is all right. Male baby was delivered, but absolutely fresh stillbirth. and it was a true knot. God is above Babas and Mamas.
Okay,
And
that saved you.
a decision versus deviation. I think don't do that. Similarly, if you have decided a cesarean section on a particular day and a patient is presented to you 2 days before at dead of night at 12 o'clock, you examine and find out you have decided that it will be done at least 3 days after that, and the patient is having mild pain. You say that yes, the patient is not in labor, I will go to sleep, and then morning I will do it. I will not recover. Even if it is a problem for you, you do it then and there for that. Otherwise, you will repent for that. I have repented for that also.
Yes, very true things, sir. Because a lot of counseling is required, and again, firm decision we have to take.
If there is no technical hindrance, then you can change it. There is not a problem. Otherwise, I think decision versus deviation, you don't do it.
Yeah, that we have to balance. Thank you, sir. Thank you. Namaskar.
Sir, we have
Sarita's face is visible now. Sarita's face is visible. Raipur. Sarita, this has given me opportunity to see my beloved faces.
And I'm just watching you for this third webinar today continuously.
I'm there from
Thank
2
you so
o'clock.
much
2
for being
o'clock
with us,
till,
sir. I'm just going to ask you one question.
yeah.
Yeah, that question is, if you are doing the myomectomy during the cesarean section,
Yeah.
is the closing method differ in some other way, or regarding the use of the suture material to achieve the better hemostasis?
Now, I have told when there is a 20 centimeter myoma in a bed, you compare intracavitary versus outside incision. The outside incision, if you give it, it becomes, say, 20 centimeter myoma, you remove it and it becomes 10 centimeter.
Okay.
If you do an intracavitary myomectomy, the whole duration, whole incision is squeezed to 2 centimeter or 3 centimeter. It is better to stitch it there and there, and you find absolute hemostasis for that also. So the question of the intracavitary myomectomy is absolutely a very good method for that. Regarding the suture material, I think the all same vehicle can be used for that also. There is not a problem, but a good closer with the hemostatic suture and dead space has to be taken into account for that.
Okay, sir. Thank you so much.
अरे भागलपुर का क्वीन आ गया. भागलपुर का queen. You are absolutely good. I must congratulate the technology part. With the initial disruption, now I am happy that I am asking my all favorites for that. Yes, Pratibha. Thank you and salute to your father-in-law, Dilip Singh. And love to Sanjay.
And I really liked your this series of Gurukul. We will be attending this, and it is really today we have learned so many things in this. I just want to ask one thing.
You have become my teacher. How is that you have learned from me? Tell me.
I cannot be your teacher, sir. You are our teacher.
Yeah.
Sir, for head delivery, we are using vacuum. What is the disadvantage of using forceps? I mean, can we use forceps also?
Absolutely. Before vacuum, I also use forceps. But I have a bad experience on forceps. Number one is that you cannot find out a good cephalic application. You do not know, even if you know the suture is this side and that side, you cannot introduce that. And second is that if you have a bad impression and both sides is locked and it's not a cephalic application, it will have a depressed fracture also. So therefore vacuum is absolutely good. It's elastic vacuum, not metallic, where the cephal hematoma is less. Medium size vacuum is good, and just you have to only find out it is not applied over the face or over the ear, and that you can easily find out. Anywhere you can use it, and that is also very good and superior to the forceps, which I have, even with Vectis also I have found a lot of problem with that. That's why an extension is more in a vacuum. Extension of incision will be more in a vacuum. rather than this, more in forceps rather than in vacuum. Vacuum extension is less.
There is one which has come with the Vactis, like a Vactis you can use, and it is, adjustable. This is the new forceps they have come up. So, can that be applied? Because
no, I will be accepting the forceps if it is a magical forceps. You apply the blade, automatically it will reshape it and find out and apply cephalic application and deliver it. Then I will accept it. Otherwise, whatever Vactis or whatever, it cannot have a good application for that.
Vacuum we are applying and we are very comfortable with it, but I have seen
You are happy or not? You are happy or not?
I'm very
You are happy with vacuum? Stick to it. And you will be happiest. You will be happiest with vacuum.
Thank you so much, sir.
Thank you.
See you on Teachers' Day, so thank you so much.
Thank you. Wishing and planning to go to Bhagalpur if everything normal is there, because I know you conduct the conference, Bhagalpur Society Conference. You can shift the year also. 2012 का conference 2013 में करेंगे, and I still remember all my favorite are there, Bhagalpur.
Thank you so much.
Thank you.
From Bhagalpur.
So, Dr. Mahapatra, now I think you have a big fan following, and there are 148
many lovable persons across India. And when they told me, and that's why I told you that I want to see the face of
Yes.
my.
So, sir, now we have about 100
They should love my lecture.
questions.
They
So we
should
won't be
love-
able to take up all the questions.
One thing I must tell them, that they may not love me, but they should love my lecture and my material, whether it is beneficial for them also. If it is not beneficial, throw that. Otherwise, they think the wastage of everything will be there, the company side and my side, and the
Right. Definitely so, sir. So everybody is loving you, and people have a lot of curiosity. They have a lot of inquisitiveness at this moment to ask you questions like, right?
I'm blessed by God that many people love me. Yeah.
Good evening,
Dr.
sir.
Ashwin, hi
Good
there.
evening. Very informative, sir. I just love to watch your lectures and hear you always. You are teachers of teachers,
Again,
sir.
wishing both
I've
of you-
learned a lot from you.
Again, wishing for the again. You must teach me again. Again, you have come.
No, that is not possible, sir. But we are really grateful for your knowledge which you have brought.
No, I'm not a very knowledgeable person. Whatever I do, I just expressed it. I just vomited whatever I have taken it.
Right, sir. So with this, I think we can wrap up the session.
Yeah.
Because a lot of questions are there otherwise. If
We can do that. You can give me so that I can clarify in the next session, because we'll continue this next session with the solving clinical dilemmas related to cesarean section.
That is right, sir. And with this, I would like to hand over the session to Mr. Alad Mahajani to conclude, and thanks to the speaker. Mr. Alad?
Alad, it is your brainchild. You conclude. You started, the one maintained, you conclude.
Yeah. Not my brainchild. Let us be very clear about it, sir. That it has been guidance by you, initiative by you. We have just been the vehicle, in terms of transferring your knowledge, the e-way to the participants.
No. Your effort is more, and all things are really compliment to PK Goa also for that.
Yes. In fact, sir, Mr. PK Goa initiated this all after having a discussion with you.
Good.
Sir, on behalf of Juventus, I cannot thank you enough for your time, for your valuable guidance. And I'm sure there were about 1,800 participants, sir.
Good.
There were about 1,800 participants.
I am blessed.
Yeah, and I think so that every participant must have gained something. And if every participant has gained something, I think so Juventus has gained something. because we have been instrumental in passing this knowledge the E-way from you to them. So we all from Juventus heartily thank you, sir, once again. And we also heartfelt thanks to each and every participant. And we request each participant to join all the 6 sessions which sir is going to conduct. Just to highlight that everybody can have a direct interaction with Dr. P C Mahapatra live. Only one suggestion is that you have to log in through Google Chrome, which will make things very simple, and also it will help a better interaction. So having said that, once again, sir, thank you so much.
I think that is very important. Allah give importance to that, whether they will be feeling very good and all that. And tell the technology people without interruption, flawless, they should do it and all that.
Yes,
and give the feedback questions, Dr. Devan. I think I'll be happy if there are some unsolved thing and all that feedback questions to give it, so that I can try to solve it in the next video.
Sure, sure. We'll do that, sir. Thank you so much.
You are a good moderator.
Thank you,
Devan
sir.
has moderated very well. I'm so happy with, and I thank you people. Juventus is a part of the family. I consider that it's my own relationship, emotional relationship with you people has culminated this particular event, and we'll continue to have this event for the benefit of the viewers, if at all they are benefited. If they are not benefited, we'll stop it then and there.
So thank you so much. I think it's really very, very valuable from your side.
Thank you. Thank you very much. Thank you. Bye-bye.
Bye, sir.
Bye.